Okay, looks like we have a lot of participation. Thank you, everyone, for joining tonight and attending our Ahead of Cancer lecture series sponsored by the Allegheny Health Network Cancer Institute. My name is Crystal Ross. I'm one of the service line directors for oncology, and we are excited tonight to have Dr. Richard Fortunato with us this evening to talk about hereditary colon cancer, more than just your family portrait. There are a few housekeeping items that we want to review before we start. During the presentation, all participants can type questions into the chat portion of the Zoom connection. If we have time, we will be addressing these questions with Dr. Fortunato at the end of the lecture. Participants are not able to speak during the conference, but again, we encourage feedback via the chat. Dr. Fortunato is a board-certified colon and rectal surgeon and associate professor of surgery for both the Drexel University School of Medicine and the Edward V. College Osteopathic Medicine. He works at Allegheny General Hospital in Pittsburgh, where he is the associate program director for the Colon and Rectal Surgery Fellowship, associate program director for the General Surgery Residency, and co-chair of the Allegheny Health Network Rectal Cancer Center of Excellence and the Pelvic Floor Center, and is head of the robotic surgery teaching curriculum. Dr. Fortunato has a strong research interest and has published widely in his field and has served as co-editor of the World Journal of Colon and Rectal Surgery. He is currently the treasurer for the International Society of University Colon and Rectal Surgeons, and is also the president-elect for the American College of Surgeons, Southwest Pennsylvania chapter. Tonight, we'd like to welcome Dr. Fortunato.
Hello, I'm Dr. Richard Fortunato. I'm a colon and rectal surgeon with the Allegheny Health Network, and I would like to thank you very much today for taking the time to listen to me talk about colon and rectal cancer. There's a lot to talk about. There's a lot of myths out there. I'd like to sort of educate you, update you, and let you know what we have to offer here in your own community. Well, this is sort of how I see the world. Today, I'd like to go over what is colon cancer, who gets it, how do we treat it, how do we screen for it, and give you a summary. What is colorectal cancer? It's cancer of the large intestine. And when we look at the anatomy, when we see your esophagus and your stomach, you have a small intestine and then your large intestine. And that large intestine is separated into the colon, which is the area above the hip bones, and the rectum, which is the last 6 inches of the large intestine. But we're essentially just talking about large intestine cancer. Well, why do you get colon and rectal cancer? Because the colon cell develops into a polyp, and that polyp develops genetic abnormal changes. It gets bigger, larger, and eventually grows into a cancer. This is called the polyp to cancer progression. It's very important about how we identify, screen, and treat large intestinal cancers. Well, what's the problem? I know what you think. It's not a very common problem. No one I know has it. It's just for old people. And it doesn't affect me. I'm here because my wife told me to come here. Besides, I don't have anybody in my family that's had colorectal cancer. It's not my family history. I don't have any symptoms. And I eat healthy. Well, let's look at these. It's not very common. It doesn't affect me for various reasons. In fact, it is a big problem. Colorectal cancer is the third most common cancer in the United States for both men and women. In fact, estimated projections till 2050 have it increasing in its incidence, again, significantly affecting both men and women during your lifetime. It's also the second most deadly cancer in the United States for both men and women. So we go back to what you're initially thinking, that it's not very common. It's very common. And it doesn't affect me. It does affect you. regardless if you're a man or a woman. In fact, you are more likely to die of colon cancer than breast cancer, or colon cancer than prostate cancer. That's how common it is, and that's how significant it can be. Well, who gets colorectal cancer? It doesn't affect me because I don't have any family history. I don't have any symptoms. I eat healthy. Well, let's look at risk factors. There are genetic risk factors. People with a family history of colon cancer do have a higher risk than people that don't. People that have a personal history of colorectal cancer are a higher risk. There are some intestinal diseases of inflammatory bowel disease like Crohn's disease or ulcerative colitis that can increase your risk. Age increases your risk. The older you get, the higher your risk of getting it. There are other factors, your ethnicity. African Americans are more likely to get it than Caucasians or Native Americans. People of lower socioeconomic status have a higher risk of colorectal cancer. Bad diet, we can talk about that. People with diabetes, smokers, obese patients. 60% of Americans are obese. That means you have a BMI of 30 or above. And 10% of Americans are morbidly obese, meaning you have a BMI above 40. This is a significant risk factor for getting colorectal cancer. Decreased exercise, also independent risk factors for getting colorectal cancer. Well, let's look at the genetics in colorectal cancer. Nobody in my family has colorectal cancer. I'm not going to get it. Well, there is a high risk if it runs in your family. About 25 to 30% of people that have colorectal cancer have a high risk family reason. About 10% of those patients have a genetic reason. Now, we can do a blood test and tell you exactly why. But 75% of people with colon cancer are average risk. They don't have a known family history, whether it's a genetic test or by looking at their family portrait. Said more simply, 3 out of 4 people with colorectal cancer have no family history of it. It does affect you. Well, I eat healthy, doc. I work out. Bad diets. Well, let's look at diet. We know it's another risk factor. We talked about that before. Well, let's look at common cancers in Europe. They have a different diet than us. Colorectal cancer is the second most common cancer in women and the third most common cancer in men. And it's the second leading cause of cancer-related death in Europe. All right. Well, they eat pretty similar to us, doc, so Europe's not a great comparison. Okay. How about Asia? It's the third most common cancer in Asia. In fact, these are projections in pink current to purple in 2040. So just like in the United States, there's a significant increase in incidence of colorectal cancer throughout Asia. What about Africa? They definitely eat differently than we do. Again, colorectal cancer, one of the highest for men and women in incidence and in death. So if you take the entire world, you can see colorectal cancer, regardless of your diet, whether you're vegetarian, vegan, eating an American Western diet, colorectal cancer is the third most common cancer in men and in women, and one of the second highest leading related cancer deaths. So who gets colorectal cancer? Everybody. It's a you problem. Well, if we go back and look at those risk factors we talked about before, genetics and other risk factors, probably the number one risk factor is age. Well, that kind of goes back to what you thought. This is an old person problem. Well, not necessarily. 90% of people with cancer are over 50. That's true. With the mean age at 67. I bet you that's a lot younger than you thought. I would bet that's probably the average age of this room. There is an increase in incidence of people getting cancer under age 40, and we don't know why. About 4% of patients diagnosed are under that age. It is very common. it does affect you in multiple ways. And regardless of how healthy you eat, it's a you problem. It will affect you. Well, how do you know if you have colorectal cancer? I know what you're thinking, Doc, I don't have any symptoms. Well, what kind of symptoms could you have? You can see here, as this polyp gets enlarged into a mass within your large intestine, it could cause bleeding. It could cause a change in your bowel habits, diarrhea or constipation. It could cause pain. It could get really big and cause a blockage or rupture. And we all know that cancer can lead to weight loss. The problem is 75% of people with cancer at the time of their diagnosis do not have any symptoms. Again, 3 out of 4 people with cancer don't have symptoms. And this makes total sense because you're dealing with an organ that you're designed not to feel. Thank goodness we can't feel our colon as sensitive as other organs in our body because you wouldn't be able to function. And it's in an organ that's designed to stretch, to let stool go from solid to liquid and hard and bulky to get through. So it's designed to stretch and not be felt. And so it takes a long time until it's advanced, you don't get symptoms. Well, that leads us to screening. What are our screening guidelines? We've lowered the risk of colon cancer screening to age 45. This was done many years ago because we noticed that patients are getting it a little earlier and we want to prevent it by removing those polyps before it goes on to progress into a cancer. So if you have no risk factors, it's age 45. If you have a family history of cancer or polyps, because remember, polyps can turn into cancer, you may have to do it in a number earlier than age 45. Same thing with high-risk people. If you've had cancer before, we'll follow you more closely, or patients with genetic reasons. There's several different classifications of screening tests. There's stool testing, there's radiology testing, and there's endoscopic or camera testing. Starting from the most basic, the fecal occult blood test, you get a stool sample, you smear it on here, and it turns blue if it identifies blood. Not very sensitive. You could eat a hamburger and it could make it look like it was blood even though it's not. But this is a basic test. We have more sophisticated blood tests, a fecal immunochemical test where you get your stool sample and you rub it on the kit, and that kit is more sensitive to blood with special markers and to make the test a little more helpful. Well, let's talk about Cologuard. Everyone's used to seeing Cologuard because the commercials come on at 3 in the morning and it convinces you that it's important. And I can avoid doing a colonoscopy if I just do this stool study. How great is it? It's 2023. Well, Cologuard is not a screening test because it detects cancer. It doesn't detect polyps. And the reason is because cancer cells are shed into the large intestine. And when you have a bowel movement and you get that stool, you can test for these genetic changes. So it's important to realize that it tests for cancer, not polyps. And the whole point of screening is to prevent cancer formation, not just to detect. Cologuard also is very involved. You've got to have a bowel movement, you've got to store it, you've got to ship it out. So it does have some complexities to it. Well, we can do radiology tests. These are better at identifying things. This is a barium enema where you drink a bowel prep. You go to the radiology department, they put a tube in your bottom and they squirt liquid around. And they can find blockages such as in this x-ray here. This is good because patients who are on blood thinners or patients who can't tolerate anesthesia can have this procedure without having to worry about those factors. CT colonography is made famous by Katie Couric on the Today Show. It's a CAT scan colonography. And that's really good. You can get really these very impressive images, and you can see the polyp was seen on the left image, and then they reconstructed the model. They can see it in the middle, and when we did the full colonoscopy, sure enough, there was the polyp just like the computer identified it. And again, this is very good for patients who are on blood thinners, patients who have blockages and you can't have a colonoscopy, people who can't tolerate anesthesia. And then we have endoscopic viewing or camera viewing, flexible sigmoidoscopy. This is where you clean yourself out, you put the camera in your bottom, and you take a look. And you can see the camera goes all the way up about a third of the colon. The problem, of course, is that it only views a small amount of the colon. So you could have a cancer on the opposite side that's not detected. So there are roles for this, but it is not a full colon cancer screening. And then, of course, there's colonoscopy. And this is what you're thinking. Here's me, one-on-one, mano-a-mano with the bowel prep. I'm going to sit there, I'm going to drink this thing, I'm going to force it down because somebody told me to do it. Well, colonoscopy, like the flexible sigmoidoscopy, you drink the prep, it flushes you out. We put the camera under, you get sedation, you go to sleep, put the camera in your bottom, and we go all the way around to look at the entire large intestine. Bowel preps are much better now than they have been in the past. We can do very simple things like a Miralax prep. You can get Miralax over the counter, and you can drink it with anything that you like, with a few certain exceptions. But it makes it much more palatable. It's truly tasteless and odorless prep, and it's not granular like a fiber supplement. It dissolves very well, so it's very easy to tolerate. We also split the doses nowadays, where you do one dose, half of it, 12 hours before the procedure, and then you do the second prep 5 hours before the procedure. Again, splitting the dose splits the volume that you need to drink. It allows you to tolerate it better, but it also gives you a cleaner colon, which is important for me. Because when I do this procedure, even though it's under anesthesia, it takes about 30 minutes, I want to see the picture on the left, a nice clean colon. If there's a big polyp like there is in the middle, or a cancer like on the right, I need to see it. And if you do the prep partially, you may say, Doc, it's nothing but diarrhea coming out. But if it's not clear, even liquid stool can block what I'm looking for. And the whole reason is to get a good look. So make sure you do your prep and evaluate it carefully. The reason why colonoscopy is so good is because you can see the entire large intestine. It can also identify and remove those polyps before they become cancer. Because of this, you only need to do it every 10 years. But it can also diagnose other diseases. There are other problems in the large intestine, not related to colon cancer, that may be identified on colonoscopy. Well, what screening option is best for me? So we look at that classification again from stool to radiographic to endoscopic. You can see the accuracy of the stool tests are not very good, even including Cologuard. About 50 to 70% accurate that they find something. And you got to do it every year. And there's no treatment once they find something. The radiographic ones, again, they're much better in their accuracy, about 90 to 96% sensitive in identifying polyps and cancers. But you got to do them every 5 years because they're not as good. And then, of course, sigmoidoscopy we talked about only sees a part of the colon, and colonoscopy. If we look at colonoscopy, clearly it's the standard. It's the most accurate in identifying things. And if it's normal, you can go the longest frequency before you need a repeat test. And of course, it's therapeutic, meaning if we find something, we can biopsy it, sample it, or completely remove it. And another way of sort of looking at all these screening tests is that everything else, whether it's stool studies or x-ray studies, if they find something, you've got to then go have a colonoscopy. And if we look at our national colorectal cancer screening rates, only about 50% of patients over 50 have had a colonoscopy. That is very, very low. It is steadily improving over the decades, but has a long way to go. And there's a significant disparity by education, income, insurance status, ethnicity, and race. And this is the reason why lower socioeconomic people have a higher risk of colorectal cancer. I know. Most people feel like I've got the worst job in the world. And I have an identical twin brother, and he reminds me constantly that I spent 30 years in school to stick my finger in people's bottoms. But the reason why I think that this is the best job in the world is because it allows me to prevent cancer. The benefits of screening are without a doubt. It can prevent cancer. By identifying and removing those polyps, it can prevent the cancer from even forming. In fact, it decreases your overall lifetime risk of colorectal cancer by 70%. And if you have a cancer and we do a colonoscopy, because most people don't have symptoms, we are more likely to identify it at an earlier stage, and that allows significant survival benefit. Because you don't have symptoms with colorectal cancer, the majority of the time, 1 in 4 people with colon cancer are diagnosed by the time it's already spread. That's why it's such a deadly disease, because you don't have the symptoms, so you don't get tested. And by the time we identify it, it's late stage. So by doing this early detection method, you can actually significantly reduce your risk of getting it and improve your survival if you have it. And if we look at the Preventative Screening Task Force from the United States, we can see that only a few cancers actually have sufficient evidence to have prevention. Cervical cancer by women getting a vaccine or an annual pap smear, colorectal cancer by our screening methods, and breast cancer. Lung cancer, prostate cancer, all the other cancers don't have evidence to prevent its detection or to identify its detection and prevent its progress. In fact, don't take our word for it. Take Consumer Digest. Okay, here you can see, get these screenings: cervical cancer, colon cancer, and breast cancer. In fact, they go on to say avoid screening for other cancers: bladder, lung, skin, oral cancer, prostate, because none of those tests actually screen for cancer. They are all detected after it's already there. Well, why is screening not very prolific in the United States? There's lots of reasons. There's a low awareness that colorectal cancer is a personal health threat. That's what we just talked about. Well, I don't have symptoms. I don't have a family history of it. It's only for old people, etc., etc. Lack of knowledge about the screening benefits, as we just discussed. There's, of course, social stigmata. It's embarrassing to talk about. It's uncomfortable. People don't like it for themselves. A lot of spouses don't even know that their spouse is having symptoms or other things like this because they don't want to talk about it. It takes time to get tested. There's a cost associated with it. Access isn't the same for everybody. And this one is a big problem. My doctor never talked to me about it. In fact, about a third of patients say that their primary care physician never talked to them about the risks and the benefits of colorectal cancer and its screening. Well, everybody here in this audience, be duly noted and warned, you've been talked to about it. So spread the word. Let's face it, it's poor marketing. We know that breast cancer is every October. Every NFL team wears pink tennis shoes and bands, and that's fantastic. And they should get their recognition. But you're more likely to die of colon cancer than breast cancer. And nobody markets because it's not something cool to talk about. Well, I will give you a marketing slogan. Give me 10 hours of diarrhea, and I'll give you 10 years without cancer. Sounds to me like a better than fair trade. Well, Doc, I got my colonoscopy. Unfortunately, I was diagnosed with cancer. Now what do I do? Well, we have you covered. AHN Cancer Institute has a very comprehensive colorectal screening and treatment program covering the entire Pittsburgh greater area. We have very dedicated experts. I'm the program director of our colon and rectal surgery fellowship, where we train surgeons after their general surgery to become specialists in colorectal surgery. Every one of our colorectal experts is double board certified in colorectal surgery to treat you. We are a Rectal Cancer Center of Excellence, which is a very high designation. We were the first one in the state and the 6th one in the country to receive this very prestigious recognition, which I'll talk about. There are many surgical considerations to evaluate. Anatomically, where is the tumor? Is it in the colon? Is it in the rectum? Is it on the right side, left side, etc.? What was my reason for getting it? Some people can get it because of family reasons. That needs to be looked at further. What's the patient's overall health? Are they obese? Are they thin? Do they have lung problems, heart problems, diabetes, or other things? Are they older? They have difficulty getting around. All of these things are very important to consider when looking at treatment. And anastomosis is the fancy term for reconnecting somebody. Do I need to get an ostomy, or the bag, as people call it? Most people don't need an ostomy. Let's just tell you that up front. What kind of surgery? Open surgery, laparoscopic surgery, robotic surgery, and other sorts of things. All of these are very, very important to consider when figuring out your best treatment. And when we go back and look at that large intestine, again, the upper part's the colon and the lower part's the rectum. Well, you can see from a surgery point of view, if it's on the right side, I can completely remove that and reconnect you. If it's on the left side, we can remove it and reconnect you. Different sections, easy to remove and reconnect. Rectal cancer, that lower portion, again, we can remove it completely and we can reconnect you. Most people with colon rectal cancer do not need an ostomy. If they need one, it's just for surgical healing. The majority of the time, it's temporary. So there's a lot we can do to get you reconnected. Sometimes, if the rectal cancer is very low and involves the anus, sometimes we need to remove it and give those patients a permanent bag, but that's the minority. Just for education, an ostomy is when the intestine comes to the skin like this and you catch the contents in the bag. On the left would be a permanent one as an endostomy. On the right is a temporary one where we form it this way until you heal, and then we take the ostomy down completely. Well, if we look at colon cancer, we all know there's many stages of colon cancer: stage 4, stage 3, 1 and 2. Colon cancer is pretty straightforward. So if you have stage 1 or stage 2 cancer, you go to surgery. We can remove it, reconnect you, and we just put you in a close surveillance program. You don't need anything else. No chemotherapy or anything like that. Stage 3 colon cancer, you have surgery, you get it out. Those patients have lymph node involvement, which means the cancer's moved outside of the colon, and because of that, those patients then need chemotherapy. So of the 4 stages of colon cancer, 3 are treated by surgery. So you want to get in to have an expert surgeon and team tackle this right away. Now, stage 4 cancer is far away spread. It's very tricky. It involves lots of other factors and will be a multidisciplinary approach to that individual. This is the treatment for just stage 1 rectal cancer. Rectal cancer is a very complex problem. And even though it's a large intestinal cancer, the tumor biology acts very differently. Where it's located is very different, and its function is different. So just stage 1 rectal cancer has over 15 ways to treat it. Stage 2 and 3 rectal cancer, again, many, many complex factors to look at. So rectal cancer is a very complex entity, very different than colon cancer. And the differences, of course, are because you've got a tumor packed into a very tight place. The bladder's there, the prostate's there, the vagina's there, the tailbone, the anus is there. And getting somebody reconnected is very, very important. And it's something that we strive to do and can do in the vast majority of patients. Well, how do we do these operations? Laparoscopically, robotic, or open? Well, laparoscopic surgery, as you can see in that picture, is when you make the small incisions. Robotic surgery is the same thing. It's a minimally invasive surgery. It's basically laparoscopic surgery using robot arms, where I sit at a console next to the patient, but don't touch the patient. The robot arms go in there, and it allows us to do very complex things very precisely with very minimal tissue damage. And we can do these for colon cancer and for rectal cancer. We can even do transanal excision, which means removing through the anus. If we look at the benefits of doing these minimally invasive robotic and laparoscopic surgeries, they're very, very important. You can see patients' ability to tolerate food, hospital stay are pretty low. But the important thing is that they can return to work a lot faster and get back to other full activities a lot faster. And the complications across the board are significantly less. So the standard of care for colon and rectal surgery and treatment is a minimally invasive surgery. In fact, we are the third busiest robotic colorectal program in the country. All of our 6 board-certified colorectal surgeons are well versed and trained in minimally invasive and robotic surgery. Some rectal cancers, we can even do robotically or laparoscopically through your bottom. That's right, outpatient day surgery for rectal cancer. That's how complex and comprehensive our identification and care and treatment model are at AHN. Well, what are my take-home messages? Colon and rectal cancer can be prevented. Screening reduces death. If you have no risk factors, no family history of colorectal cancer or polyps, you start at age 45. It is no longer 50. Patients that are higher risk based on those family history or medical conditions may need to be seen sooner and have closer evaluations. And there are many, many effective screening options. Not screening is no longer an option. So I will tell you the #1 risk factor for colorectal cancer is not getting screened. The American Cancer Society estimates that 90% of cases and deaths of colorectal cancer can be prevented. If you do get diagnosed with colorectal cancer, AHN has you covered throughout the hospital, throughout the Pittsburgh area. Our dedicated experts, minimally invasive specialists, and very comprehensive care will take care of you. I'd like to thank you very much for your attention. This is my office number should you need to reach out to me, and I'd be glad to take any questions.
Thank you, Dr. Fortunato. You always amaze me in your talk, so thank you. We do have a couple of questions in the chat. We have a person who is 54 and she usually has 1 to 2 polyps removed every 5 years during her colonoscopy, but usually they are completely benign by pathology. The last colonoscopy I had 4 years ago, they removed 2 tubular adenomas. It has still been recommended that I only have a colonoscopy every 5 years. Is that still sufficient time given my history of tubular adenomas now? As an aside, my mom passed from sigmoid cancer at age 71.
Yeah, good question. Thank you all very much for your attention, and thanks for the opportunity to speak. I really appreciate it. This really is probably the biggest prevention that I could give, is to give knowledge out to the community. You all obviously are a captivated audience that are here on your own, so I put it on you to spread the word out to everybody else that wasn't here. So thank you very much. That's a very good question. It comes down to a little bit of terminology, if I could just sort of clean it up a little bit. Every polyp you remove is benign, but the polyps are precancerous, like we had talked about, because there's a progression from a normal cell to a polyp to a cancer. So every polyp that gets removed, based on the number of polyps, the size of the polyps, the type of the polyps, they all have different risks associated with it. And so that will set up your sort of individualized colon cancer screening or endoscopy requirement. And I kind of like to think about it like you want to stay on a surfboard surfing on top of the wave. You don't want to get in front of it because you miss it, or you get behind it and you have a problem. And so the issue becomes is you may have been getting surveillance colonoscopy at a closer interval, and now you're producing smaller polyps at a lesser volume. And so the kind of the leash gets extended as far as, how often you need to survey somebody. And so that's the first thing. So there's no, I get a scope every year. That doesn't happen anymore. It's very individualized based on the number, the size, and the types of your polyps. The other thing too is we have had a change in our guidelines over the last 2 years. And so we are now implementing the newer guidelines in order to appropriately cover people the right way. And so you may be seeing sort of a reflection in the old statement of you'll never go 5 years, or you never go 3 years without a scope, to one of a longer interval based on those factors. And so it always becomes a little bit tricky, but it sounds to me ultimately like you have a very involved physician who's appropriately tailoring your surveillance to get the highest yield, to identify polyps and remove them. So it sounds like everything is in order.
Thank you. Oh, these questions are just coming in. If there is a family history of colon and rectal cancer, how often should the colonoscopy be performed?
Yeah, so family history is a difficult term because there are family histories where everybody in my family has it. And then if I do a blood test, there's no genetic reason why I have it. So we don't have colon cancer screening recommendations for just a lot of people in your family with cancer, but we do have colon cancer screening for, hey, I have HNPCC or non-polyposis colon cancer or FAP or one of these other fancy names. Those are much more stringent and the guidelines are recommended. But in general, if you have a number of people with colorectal cancer, you probably will never go longer than 5 years without a scope, even if you individually don't have a polyp. And so that's kind of where we put family cancer. Like I was saying before with that slide, you're higher risk than average, but you're not in the bucket where we know the exact risk of you. So we will follow you closer than average, but there's no specific set guidelines unless you have a known genetic condition.
Okay, there's a question. You are colon and rectal surgery. Is oncology consulted for all of these cases?
Well, it depends on the practice of your physicians. In general, they don't need to be, because oncology give chemotherapy. Now, some business models or some community practices or some other doctors, they like to have the oncologist also do the surveillance, colonoscopy, CAT scans or blood work or follow-up. It just depends on how your surgeon's practice is set up. And so you will see a hybrid. So no, oncologists don't need to be involved in every case. It's really patient specific. If the patient, if you do have cancer that requires chemotherapy, then you will come back to the oncologist for certain, because they're going to want to continue to follow you. But if you don't get chemotherapy, it's not required.
Okay, 2 more questions. At my last colonoscopy, I had a precancerous polyp. Note, my mother died of colon and rectal cancer. I'm now getting a colonoscopy every 3 years. Anyway, given the precancerous polyp found, what are my chances for the next colonoscopy will reveal cancer?
Right. So again, kind of goes back to my previous question. I think we answered that based on the number, the size, the types of polyps, your personal age, medical risk factors, and your family risk factors. All that stuff kind of goes into a formula, so to speak, and we tailor it specifically to you.
Okay, one more similar kind of question. I'm 49 years old and my mother passed away from colon cancer at age 50. Should I have genetic testing or just continue my colonoscopies every 3 years?
Yes, you need genetic testing, 100%. And the second thing is, typically we'd say your colonoscopy would be required at age 40, which would be 10 years earlier than when your mom had cancer, and would be 5 years earlier than the current recommendation of 45 being somebody without a family history. However, if you have a genetic condition that we can see with the blood type, then you may need your colonoscopy right now or significantly earlier. In fact, your children, siblings, nieces, and nephews may all need to get tested because there are, like I said, very strict other criteria for known genetic anomalies. But if your mom had colon cancer at 50, then yes, you you are recommended to get a genetic test, because that will survey not only how often you get a colonoscopy, but a lot of these have other cancers associated with colon cancer that you may need to have screened. As far as it every 3 years, there is no set number for, hey, my mom was 50, she had cancer, we have no genetic abnormality. But again, sounds like this doctor is being diligent and checking you sooner than the average person on a close surveillance. So every 3 years is a reasonable starting point that for them.
And then just one last question. Should you be concerned about tissue in your bowel movement? So I'm not sure.
So if you're passing things that look like blood clots or tissue, absolutely, you need to go see a physician right away.
Okay, well, that was really great. We really appreciate all the comments and all the feedback for Dr. Fortunato. Dr. Fortunato, again, thank you for this really informative discussion. And if there are no other questions, we'd like to thank all of you for attending our Head of Cancer Lecture Series event. Please continue to join us at our monthly lecture series as we focus on cancer screening, detection, treatment, and survivorship. As a reminder, tonight's lecture was recorded, and if you're interested in re-watching the lecture, please check back on the AHN YouTube channel for the full recording. This video, as well as other past lectures, will be posted under the Ahead of Cancer playlist. And if you would like to schedule an appointment or have any questions regarding a potential cancer concern, please call the Hope line at 412-578-6473 to schedule an appointment. You may also call our 24-hour Nurse for You line at 412-687-4968. Thank you again for joining.
Take care. Thank you.
Thanks, Dr. Fortunato.